Thank you, Camille, and thank you to Vitaflo for having me. I will be talking about the Glycogen Storage Disease and pregnancy on the liver transplant list. Firstly, I'll do an introduction as to why I'm presenting on this particular topic, and then I'll be setting the scene before I go into the details of the case study. And then with these experiences, it is really important that we think about the next steps and what we might do differently in the future, or what we might continue to do. And afterwards, I'll be rounding up with a quick summary of our experience. So with improved treatment, more women with inherited metabolic disorders now survive into adulthood and wish to become pregnant, which is a really positive thing. And so reports of pregnancy in many disorders, they may be small, and understanding of the possible risks of, say, elevated metabolites during pregnancy and how to manage these are quite limited. So meeting the dietary needs of these patients during pregnancy can be challenging, and they may have naturally self-selected their diet throughout childhood and throughout adulthood as well. And so during pregnancy, we may experience that they are adverse to certain foods, and disordered eating is often more prevalent in this patient group as well. So changing well-established dietary habits can be quite challenging and difficult, and so enteral feeding on occasion can be indicated to maximize maternal nutrition, as well as ensuring the healthy growth and development of the fetus. So I think, yeah. So for this case study in particular, there are a few points. So for this case study, we're going to look at pregnancy glycogen storage disease type 1A. Whilst on the liver transplant list, we're using a nasogastric feeding tube throughout the entirety of the pregnancy in order to meet maternal and fetal nutritional needs and to prevent hypoglycemia. So there's a few points there that we have to look into. So just to give you a bit of background, the patient was diagnosed with glycogen storage disease type 1A at 3 months of age and treated with nasogastric feeding overnight alongside daytime infant milk formula. And so from the age of about 5 months, uncooked cornstarch was introduced alongside a normal weaning diet. And also here, fructose and lactose were restricted. So throughout childhood, the patient was managed on a normal diet. It's important to mention there, however, with a fructose and lactose restriction, including daytime uncooked cornstarch and nighttime nasogastric feeding. Now, she did present with a history of fussy eating and also anorexic behavior with associated amenorrhea. So unfortunately, the patient stopped engaging with the pediatric services, and so she was never actually transitioned to adult services, and so therefore lost to follow-up. However, at the age of 24, she presented to the child metabolic unit with a few issues. So she had significant abdominal pain. She also had a hypertrophied right liver lobe. She also had inappropriate postprandial hypoglycemia. She also experienced migraines associated with nausea and poor oral intake. And so with that, this ultimately resulted in food refusal, and also to consume adequate amounts of food. And so therefore, a 24-hour nasogastric feeding tube was initiated, despite vigorous dietetic and medical input to try and optimize her oral intake, but it was just, she was refusing. Although physiologically, she was perhaps able to eat enough to maintain her blood sugars, but she refused to. So we found that she was metabolically stable on a nasogastric feed of 3.5 grams of carbohydrate per kilogram, and so that was over 24 hours. She was also taking isotonic drinks orally, so that provided an extra 130 grams of carbohydrate per day, roughly, depending on how much she was taking, and so this was when she was being compliant. So that same year, unfortunately, the patient was diagnosed with a hemangioma and placed on a liver transplant list. So at this stage, unfortunately, the patient's liver was pressing on the spine, and so therefore compressing the diaphragm, resulting in pelvic and back and lower abdominal pain, as well as episodes of numbness. So sort of between 2010 and 2014, we had a few issues with her, and so she was continuously paused on the liver transplant list, and that was due to gynae surgery, which of course she couldn't help, but also a self-confessed opiate addiction. She also had poor metabolic compliance. She would stop and start her feed as and when she felt like it, and we had next to no blood glucose readings to assess her metabolic control, really. And also, unfortunately, she reported that she had 5 miscarriages during this time. So in 2014, she notified us that she was 7 weeks pregnant. So an emergency appointment was made with ourselves, so the metabolic team. We also made sure that she was seen by King College London for the liver transplant team. We also notified the local community dietitians because they're the ones that are in charge of the plastics and ordering the feeds. And we also made sure that we did a sort of urgent obstetric referral to make sure that she was seen on every account. So in the first trimester, her baseline weight was 70 kilograms. And so we found that she was metabolically stable on a feed of 4.3 grams of carbohydrate per kilogram. Now, it was really hard to assess her current metabolic control at this stage because we had nothing to go by, and at this point, we just wanted to initiate her feed as soon as we could, because we weren't able to see, or she wasn't able to come into the unit until a week after she notified us of her pregnancy. However, we recalculated her requirements and got her to do some blood glucose readings at home because she had everything in place. So she had the strip, she had the meters, and she knew exactly how to do her blood glucose. And somehow, and I think in a lot of metabolic disorders and what was discussed yesterday as well with the PKU, women become very motivated once they are pregnant, most of them, thankfully. So she was incredibly compliant at this stage, and she was very... she interacted with us a lot, and she really wanted to know what to do. So that was really nice, and I think that's when we started to build a really nice rapport with her and a really nice relationship. However, it's just important to say at this stage her oral intake was next to non-existent, so we had to try and really encourage oral intake and try to get her fluids up as well. So we asked her to do 3 things. So ideally, to do a minimum of 4 daily blood glucose readings, ideally pre- and postprandially, just to assess how any oral intake would affect her blood glucose. Now, it's difficult because she wasn't really eating much, so it was really just to get an idea of what the feed was doing over the course of the day. We also asked her to please treat any hypoglycemia, so any glucose readings that were less than 4, we asked her to treat with isotonic drinks and jelly beans, and that was her preference because she found that was the only thing that she could possibly tolerate, so we had to go with that. And we also asked her to really engage with us, and we also engaged with her, so to do twice weekly emails or even telephone calls, depending on what she preferred. Just to report the blood glucose reading, sort of to assess whether we needed to change anything in her nasogastric feeding. So, as always, with these conditions, we put emphasis on emergency protocols. So if the patient wasn't able to tolerate, should she become unwell, tolerate her oral emergency regimen, she is to report to A&E as soon as possible to have the IV dextrose. And also we asked that she did hourly blood glucose readings if she did become unwell. We also prescribed an antiemetic as a precaution, but thankfully we didn't have to use it at all. She actually had what we would classify an easy pregnancy from that point of view. And also she wasn't actually unwell, so she didn't use the emergency regimen whatsoever throughout pregnancy, which is quite unusual. So she gained 6 kilograms towards her sort of second trimester, and at 19 weeks, her blood glucose had leveled out. And so we took the initiative to increase her calories slightly, and that meant that she was still meeting sort of 4.5 grams of carbohydrate per kilogram. And the reason we did that, I can show you here, is because, as you can see here, sort of at 16 weeks, it started to level out. And so not that the blood glucose readings were particularly bad, they were still within range. However, we know that sort of from 20 weeks onwards, the baby starts to grow. So we wanted to almost take the initiative to increase her calories before her blood sugars drop. So that's the reason why we did that. You can see sort of at 26 weeks roughly, we had a bit of a blip, but that was because the tube became dislodged without her knowing. So she wasn't having any feed or anything orally for a few hours. And so it might actually have been a bit lower than what it shows here on the graph, but it was certainly a hypoglycemic event. And so that was almost sorted right away because she was very compliant at this point and very keen to, and also very symptomatic. So she could feel, as soon as the blood sugars dropped, she could feel it right away. So she treated it right away. You can also see from this graph that actually her blood sugars went higher than they ever were, sort of towards her third trimester. And the reason being was that her oral intake improved significantly. So she was actually eating more and drinking more than she ever had done before, which she was even surprised about. And it was quite a nice development. So as you can see here in the third trimester, we really made no change to the feed. And as I mentioned just now, that was because her oral intake improved significantly. So the plan was as before, a minimum of 4 blood sugar readings a day, to use the emergency regimen should she need it, and then be in contact with us as much as she could. And I would say that it was very much due to the compliance of the patient and her total engagement with us that a healthy baby boy was born at 36 weeks for a planned C-section. So the patient wished to breastfeed before she gave birth, and so we did put a plan in place to increase her nasogastric feeding by 200 calories with the local dietetic team. However, once the baby was born, Mom decided not to breastfeed, so that wasn't actually an issue. And so the 5 days postpartum, we just continued on the feed that she was on. And then 5 days postpartum, we were actually able to go back to baseline and return the feeding rate and volume to normal. So what happened next? We put her back on the liver transplant list as a priority, so towards the top of it. However, we were very surprised, and so was the patient, I think, to find out that she was pregnant 3 months postpartum. And so we had to then take her off the transplant list once more. I think King's College London hate us. However, she then gave birth to another healthy baby boy 9 months after that. Now, unfortunately, I can't give you the data for the second pregnancy because she's moved countries and I was unable to contact her to get that consent. However, it was a very similar outcome to the first pregnancy. We also hear that she has had a liver transplant in 2017. So sort of future consideration and things that we learned or things that were confirmed to us during this period was that we know that the knowledge of optimal management and outcomes during pregnancy for women with metabolic disorders are limited. And I think it's therefore so important that we have these opportunities to share case studies. We do posters, we communicate with each other so that we can all learn from each other and perhaps get a really good outcome like this in the future as well that might not be as straightforward as this pregnancy, because I think we were very lucky to have the nasogastric feeding tube there to kind of guide us throughout, so there weren't any major complications. It would be beneficial to have a patient registry perhaps that includes a variety of pregnancies, so that we can improve and standardize our care in the future. And so this third point is really just one thing that was confirmed to us when we went through this period, that sort of assessment and close monitoring of the patient, nutritional intake, assessing things along the way is really important to get a positive outcome. And also, we now know that we can maintain blood glucose levels at 3.5 and above with these GSD pregnancies. That's pretty much it for me. Any questions?
All right, so thank you very much, Kit. That was a great talk. Are there any questions on the floor? Oh, sorry.
Thank you, Kit. We had a very different experience with our GSD 1A patients. Yes. So she was a young girl. She was 18 when she first got pregnant, and she miscarried, unfortunately. At that miscarriage, she had a blocked peg tube. She ended up in respiratory arrest because her lactate went really, really high. So you can imagine her second pregnancy was very, for her, she was scared, really scared. Peg feed the whole way through pregnancy. As the baby grew, especially in her third trimester, the space between her peg and the line coming out shrunk. Right. So we had real problems actually managing to get her feed. And like you, overnight, during the pregnancy, it was just overnight feeding with cornstarch in the day. Okay. By the time we got to the third trimester, she needed continual feeding just to maintain her glucose levels. She was seen at St Mary's for the delivery, and the delivery team included haematology for platelets, the neonatal service. The baby unfortunately had hypoglycemia. Because of all the amount of glucose we were giving Mum, the baby had severe hypoglycemia and was put in SCBU for sort of 24, 48 hours until that recovered. Mum did really well. So pregnancy level, lactate levels all through the second pregnancy were absolutely normal. Okay. But it was that first pregnancy when the lactate went up, I think it was about 15, which then caused respiratory arrest. And it's something that I haven't actually seen documented within the literature when we looked, but it's just something that we sort of noticed.
Yeah, no, absolutely, and that's interesting because that was also a point I was thinking about during the first presentation, that we didn't measure lactate in this pregnancy, purely because we can't do it at home and the patient wasn't very good at attending hospital appointments. She had a busy life. But yeah, I think it's definitely something to look into and be wary of.
We actually didn't, we went down avoided the C-section. Yeah. So, yeah, she was induced 2 weeks early, completely normal birth, thank goodness. Yeah. Platelets were absolutely normal. I think the obstetrician team thought we went overkill. but
what if?
With the literature, precisely. Yeah. But no, the baby is beautiful. Very, very chubby baby boy. Beautiful, beautiful boy.
That's what we like to hear.
Is there anyone else?
Yeah, so it's 3.9 kilograms, so a good size. And she was also, the planned delivery was at 36 weeks because baby was big. Yeah, which I think we kind of expected.
Right. Thank you very much for your talk.
Not a problem.
All right.